So today I'm with Dr. Colin Lathrop, who is in Katy, Texas, and he took a DTR summit in last year, 2017, and ended up having one-on-one DTR certification training with me in his office. And it's now been about 8 months, and I wanted to get his perspective. I'm back training his associate today, Dr. Rob Zboril, and I wanted to get Dr. Lathrop's perspective on how DTR has impacted his practice and using the T-scan, what that's meant to his practice, and just his whole take on what DTR has been doing for his patients.
So I've been using the DTR protocol for about 8 months now. I was a previous user of TechScan for about 18 months beforehand, before taking the rest of the training. The in-office portion especially was a huge shift in my understanding of how to manipulate the teeth, to get the teeth in the correct position when we had traumatic bites and everything else. Our patients have benefited quite a bit because we're able to get people out of pain, discomfort. We're also able to adjust other people's dental work that has never felt right or worked correctly, or there's always been some pain aspect. And instead of replacing the dental work, we've been able to just make adjustments and to save it. The understanding of occlusion after using the TechScan and following the DTR protocol has actually been a big paradigm shift in our understanding in our practice. And we run a very busy practice, all full restorative, implants, reconstruction, the whole gamut of it. We have lots of facial pain patients, lots of bruxism, a lot of high stress individuals live out here, and we've been able to use the technology to really get to the heart of the issues very quickly with an extreme amount of accuracy that we've never been able to have before. Our orthodontic patients from post-Invisalign have benefited from it because we're able to ensure that once we have finished the orthodontic correction of their bites, that we have TechScanned them to ensure that we have actual data to prove that their bite is nice, balanced, and stable in full MI or in excursives, so that we can prevent them from relapsing or anything like that. So the technology integration in our practice by using TechScan has really set us apart from a lot of the other practices in the area, from the level of dentistry that we're able to provide and the level of quality that our patients have come to expect. So we would not be able to do what we do on a routine daily basis without the understanding of occlusion via TechScan or following the DTR protocols to a T, as learned in the lecture course with Robert and Ben, as well as the in-office certification. So any dentist who's doing digital occlusion, it's really the next level. It's a very easy process to do in-office, and it's great to have the world's leading expert in digital occlusion to be there right by your side with your own patients, in your own operatory, with your own equipment, with your own EMG and your own screens or whatever you're going to be using, to where you can really hone in what you're doing in your own environment. So it's a very unique opportunity that I think any dentist who is doing TechScan and digital occlusion should really look into arranging for Robert to come into the office. So I am a much better dentist, and I feel very bad for some patients that I treated years ago with restorations that now that I know the difference, I just wonder what is going on with their dental work now. So hopefully I can correct that in the future. But great experience overall.
So, you said you were a T-scan user for a number of years before you had training. So what changed because of the training?
The initial training was very basic, and I thought I understood how it worked. That was very naive. Once I took the actual training, because I wanted to get better with it, is when it really opened my eyes and I started seeing how little I really understood about the software and the analysis. That once I saw the lecture, the software covered in the lecture for the explanation, and then my own patient implementation, is when I could really understand how the software truly works, the way that it was designed. So just initial training is not enough. There's no way you can just start. That's just to kind of get you to understand how it works, how to turn it on, how to maybe take a MI bite, But otherwise, if you don't have the DTR training for the actual full protocol, then you're only getting maybe 2% of the tech scans, usage out of it. After the DTR training and everything else, you're really using it to almost to its full potential. So
you're talking about the in-office training.
In-office training, yeah. The lecture bridges the gap between the initial and the in-office, but even then, I still left and I still wasn't quite exactly 100% sure of the topics. But then the in-office, and once you were explaining it based on the patient's data, it made way more sense. And that was really the level that I needed to get over and to really be very confident in being able to use the technology and be able to explain to my patients why I'm using it and what it's for and the benefits of it. So.
And last thing, let me just see. Yeah, still going. Okay, last thing. How do the patients take to the T-scan and the EMG and being measured versus prior to when you would use this technology, previous occlusal interactions? Do you see a difference?
There's a very big difference in the patient's acceptance of the treatment once I can explain to them in pretty simple terms, especially when I hook the EMG with the T-scan and we're showing at full bite what the muscles are doing, and then once they've gone into full disclusion, what the muscles are doing there. Now, they may not understand all the data fully, but I can show them muscles are working where they're supposed to be working, and this part, muscles are not supposed to be working here, and yours are working. So we need to turn those down. And then once we do a follow-up scan and I show them muscle activity has gone down and that sort of stuff, then I have the data to back it up. I have a lot of engineers in my practice, a lot of oil and gas folks that live out here, so there's a lot of engineers, and they love the data. It really makes a big difference. Because otherwise, it used to be, if a doctor told you to do something, well, you did it. Now you have to almost prove it or verify it or justify what you're going to do or what you're doing for patients overall to accept things. There's not as much of a high level of trust for various reasons in healthcare, dentistry, no matter what it is. So there has been a shift, I believe, from the time that you had your initial training as a doctor and when I had my initial training. There was a big difference in people's respect of a doctor or the profession or any of that sort of stuff. Now you have to prove it to people before you do any work. And this is a very easy and transparent way, a very safe way of backing up the data as well to prove that what you did beforehand and what you did afterwards, and that you're making them better or tracking their decline if they're non-compliant with coming back in for follow-ups or any of that sort of stuff. But did I answer your question?
Yes. Anything else you would want to add about the general experience of becoming more capable of using the T-scan, the EMG, and the DTR technique?
From using TechScan and the EMG, incorporating the DTR protocols, I'm able to much easier now recognize patients in severe dysfunction, even before they tell me if they have any pain or anything like that. I just start to really recognize a lot more significant occlusal disease issues in patients. And then I know when to use the TechScan and the EMG to help patients understand why they may need orthodontics and restorative or just orthodontics, to where it's helped me to be a much better dentist, to be more comprehensive in nature, as well as to be able to be more conservative on treatments based on getting the bite into a good function, especially in their disclusion time, to protect the restorations that I'm doing so I don't have to redo my work, or to where if I put a patient in a overbulked restoration and now they're having a disclusion time issue, then I can readily fix my own restorative error instead of letting it go on and on and on, tooth cracks, and then I have to do an implant or whatever else. Some dentists may want to do more work on their patients, but I just really don't. I think it's better for them, the less work that we do on them. But I wouldn't be able to do that without the technology. There's a ceiling that you can get to without utilizing a TechScan and the EMG and the DTR protocol in patients, especially whether pain or reconstruction or cosmetic cases or implant therapy or orthodontics. There's just so many of the disciplines of dentistry that a TechScan is very valuable. Periodontics is very valuable for perio patients to get them balanced so that you're not having continued vertical defect formation or mobility or continued recession. So all the disciplines besides pedo, I guess, would benefit from utilizing a tech scan to some degree. It's just my opinion.
Well, it's a good opinion.
Well,
Thank you for that insight. And,
most people don't see the connection though, because most dentists don't see the connection between the tech scan, utilizing the technology in most facets of dentistry. An endodontist would benefit from a tech scan. It would probably prevent people from doing endo that may not be necessary when they're in a traumatic occlusion that finally they wore down to a point to where it put them over the edge, and now they've got a lot of severe discomfort and everything else. Periodontists, like I said, for perio patients, orthodontists for checking and verifying the occlusion of their final cases, because I think the orthodontic treatment time would actually be extended out to 2.5 years for most cases if they were analyzing it via tech scan. They wouldn't have near as much relapse. There would not be as many relapse correction cases from orthodontics afterwards if the occlusion was dialed in a way that was actually measurable and repeatable, that you can't get just from articulating paper. Of course, prosthodontists could use it because of the amount of reconstruction and implants that they do. Oral surgeons could use it to some degree, for analysis or for examinations. If they have a patient that comes in pain as well, maybe they went to a surgeon first and didn't go to an endodontist. It may not be widespread usage by them, but general dentists for sure, orthodontists absolutely, periodontists for sure. It'd be almost a requirement for them to use the technology, because the standard of care has got to change. Marking paper is just not enough. Everything else is digital in the dental office, 3D x-rays, Invisalign, iTero, CEREC, everything's digital. Why isn't the occlusion digital? Even though the tech scan was the original digital technology, yes. Right?
First one.
So it predates all other dental technology, but the first digital technology that someone wants nowadays, it's either a 3D cone beam scanner or it's an intraoral scanner or a milling scanner. Yeah. And so if you have a true digital workflow, you really can say that you are a full digital practice or a high-tech practice. And if you're still relying on marking paper to check and verify your occlusion, that's just the dark ages.
Certainly. Well, thank you for all that. And appreciate your comments.
That better.
Look forward to seeing it on YouTube. All right. Thank you.